Good evening, everyone, and welcome to our webinar on sexual desire discrepancies. Today we have two excellent speakers, Marieke Dewitte from Belgium and Alexander Stulhofer from Croatia. But before we start with the webinar, I would like to ask our President, Carlo Bertocchi, to say a few welcome words.
Thank you, Kobe, and good evening, everybody. I think that it's a real pleasure for us to host this nice webinar tonight, and I think that we are keeping going with webinars for all the month of June with some other topics that you will see later on. But I just want to take 2 minutes for you. If I can have one slide, please, Daniela, just to give you some more information about our educational project. And I think that the first important thing that I want to remind you is that we have, you can go to the next, oh, first of all, sorry, I missed the thanks to these two gentlemen that organized the webinars, that are Kobe Reisman and Giovanni Corona. And so first of all, sorry, I was thinking about the educational programs, but we need to thank these people, and this is very, very useful to do it. So, Daniela, if you go on the next one, I think it's important to remember that we organize also some very important publications. So one was prepared in the beginning of 2013 on as a manual of sexual medicine. And then the year after, we did also the syllabus on clinical sexology. And both of them are very important because they are quite a Bible of the sexology and the sexual medicine. And so I think we are very proud of this text that we are going to renew possibly very soon. And the last book that we have already finished is the textbook on surgery, and is already finished, so it will be on market very soon. And so we will be pleased to give you a chance to see these books as soon as possible. And the next slide is basically just to give you another information about our activities in education. Next year, we will start the academy, the surgical academy. And this is another step after we started 10 years ago, the School of Sexual Medicine. And so I think this is a completion of the total field of sexual medicine. And so it would be nice for everybody who is interested to improve the skills in surgery and also the knowledge about procedures to take a chance to participate to our academy. And finally, but not because it's less important, we are increasing our videos. We already have video on erectile dysfunction, but we are improving with some more videos also on surgery and other topics. And so again, if you stay with us, I think you have a chance to increase your knowledge and possibly to participate as much as possible to our activities. So that's all on my side. So I give back the chair to Kobe.
Thank you very much, Carlo. I would like also to ask our scientific chair, Giovanni Corona, doing marvelous work, to say a few words of welcome to you.
Thank you, Kobe. Good evening to everybody. It is a pleasure again to host another great success of our society. This is, I think, one of the most difficult topic because the evidence was not so high, and is not so high. But along with Kobe and Carlo, we decided to select some very hard topics like this one, and to prepare the position of our society, or to express the position of our society. The paper has been already published, so it is free because it's been published on Journal of Sexual Medicine Open Access. So you will able to join this fantastic talk, and then you can download the paper directly from the web. Finally, I'd like to thank very, very much Marieke and all as her team, not just for this topic, but also because they are going to prepare another very important topic that will be available, I hope, soon. So thank you, Marieke, and thank you, your team. And so again, please enjoy the webinar. Kobe.
Thank you so much, Giovanni. I will not take a lot of your time from the presentation, Alexander and Marieke. I'm very pleased that you are able to be here and share your knowledge and experience with us. Just a few rules for you, the attendees in this webinar. On your screen, you have a question and answer button where you can ask a question to our panelists. We will not answer the question during the presentation, but at the end of the presentation, you will be able to get answer and discuss through this question and answer with them as well. We have a chat possibility where you can chat with each other as well if you want. And last but not least, we have also pools. And during the presentation, we will ask for your opinion in a few issues where you can vote, and we will show you the results as well. Don't forget that this webinar, as our previous one, will be recorded and will be visible in our website. So Marieke, let's go on and start with the presentation and enjoy the webinar.
Okay, just sharing my presentation now. Let's see here. Okay, so first of all, welcome and thank you all for joining this webinar on sexual desire discrepancies. Now, this is a very challenging topic because, as Kobe said and as Giovanni said, there's not much evidence on it, although it's a quite prevalent condition in clinical practice, so it's important that we do put more emphasis on it. So me and my team, we have worked through the literature and we have written a paper on this. Of course, this is a joint effort together with Joanna Carvalho, Erika Limonsin, Patricia Pasquale, and Alexander Stulhofer, who is also hosting this webinar. And of course, also Giovanni Corona and Kobe Reisman. Now, sexual desire problems are one of the most common problems in couples, and most often we take more like an individualistic approach in which we reduce the problem to the individual desire levels of the partners, thereby disregarding the fact that sexual desire actually develops in the context of a relationship. So it mainly involves dyadic interaction between partners. Now, if we look at the official definition of a sexual desire discrepancy, we can state that it's the condition when two partners in an intimate relationship desire different levels or a different frequency of sexual activity. Now, we looked at the literature, we tried to give an overview, and of course we made a selection, and our final selection is based on our clinical and research expertise. Now, there's a lot of literature on sexual desire in itself as a concept, but we are not going to focus on sexual desire in a whole. We're going to see it more as a motivational, relational, and dyadic concept. Now, the evidence is limited. There are not much clinical studies at this point, so we do not have clear clinical guidelines on how to treat couples who are distressed by sexual desire discrepancy. So we cannot make formal clinical recommendations, but what we want to do is we want to give our approach to the concept, how to treat it, give some suggestions on how to approach SDD. Now, we define sexual desire from a biopsychosocial perspective. So, of course, there are biological factors involved, like hormones and neurotransmitters. But the main focus here in SDD is more on sexual desire as the motivation and the wish to behave sexually. So we define it more as an action tendency, which is of course also influenced by individual traits and partner behavior and relational societal expectations. So clearly biopsychosocial. Now, if we want to understand how we can approach sexual desire as a motivation, we can look at current models on how we approach sexual responding. Now, for a long time, we have approached sexual responding from this traditional sexual response cycle of Masters and Johnson, which defines these 4 distinct phases of desire, arousal, orgasm, and then recovery. Now, the problem is that nowadays we don't see the sexual response as a linear response, and we do not regard sexual desire as an inner drive. It's not something that spontaneously exists. It's not something that pops up out of the blue. We see sexual desire and sexual responding more like a circular response. So how does this work? Well, first of all, there needs to be a sexual stimulus, something that triggers a sexual system. That can be a thought, it can be a tactile stimulus like touch, or it can be a visual stimulus. There needs to be something, a trigger. Then we will automatically pay attention to it. It grabs our attention. We will automatically appraise it. And when we link this with memories of sexual events or something sexually rewarding, this will automatically activate genital arousal responses. And the moment we become aware of this beginning physiological arousal, we will pay more attention to the sexual stimulus. We will further elaborate on it, which then results in the subjective sense of arousal, the desire to actually do something with it, to engage in sexual activity. And so this is really important here, that sexual desire is actually the result of beginning arousal. So it just does not pop up spontaneously. First of all, there needs to be a trigger, and then it's actually results from arousal. So the question is not, do I feel sexual desire at the moment? The question is more, am I motivated to open myself for sexual desire? Am I motivated to create sexual desire? And this is important because it's quite common that when you start a sexual activity, that at that point you're still quite neutral. You're not really feeling it. But when you start engaging in sexual activity, this arousal will grow, and then also the desire will grow to actually continue with the sexual activity. So this is how we focus mainly on the motivation to behave sexually. Our current knowledge on sexual desire is mostly based on individual responses, and the focus is often on the quantity and not really on the quality or the meaning of sexual desire. If we also look at treatments of sexual desire, it's mainly about increasing the quantity, the level of sexual desire, but it's not about what does sexual desire means in the context of a relationship and how does it actually works between partners. Now, our primary statement is that problems with sexual desire do not arise from the sexual desire in itself, from the level of desire, but the fact that there's a discrepancy in the meaning or the level of sexual desire between partners. So it's not only about one partner having more or less desire than the other, it's also about the meaning, like wanting different things, preferring different sexual acts. So it's also about sexual preferences, a different object of sexual desire. It can be that one partner wants something else than the other partner. So we consider SDD, as sexual desire discrepancy, as a relative and a dyadic concept. Now at this point, there's no official DSM or ICD diagnosis. So most often the couples will present with low sexual desire, like hypoactive sexual desire disorder or sexual interest and arousal disorder. So we tend to put the diagnosis on the partner with low desire, and we identify the low desire partner as the patient. But instead of pathologizing this low sexual desire partner and then taking the high desire partner as the benchmark, it's more useful to reframe the problem as a mismatch in desire. There's a difference between partners. So it's mainly a dyadic and a relative concept. It's really about sexual desire relative to the level of sexual desire of your partner. Now, SDD would be inevitable in long-term relationships because when we think about sexual desire, it's actually quite fluid concept. It fluctuates over time. There's a lot of variation in sexual desire. It varies across the day, but it also varies day by day or during certain periods of time. Imagine, for example, when you are very busy with work and household, or also this specific time of the COVID time, this also has an effect on sexual desire. So there's a lot of variation. And what we also state is that there's a general decline in sexual desire over the course of the relationship. So in the beginning of the relationship, couples develop a certain sexual script, which is arousing, which is exciting, but it becomes less exciting over the course of the years. Now, when we consider sexual desire as a fluid and as a variable concept, then this means that SDD does not always cause distress. It's not always a problem. And when couples are not distressed by it, they actually don't need help. They don't need treatment. So the crucial aspect is when you hear about discrepancies in levels of sexual desire, we need to ask whether the couple is distressed and how much distress they are actually experiencing. And then we can differentiate between personal distress, somebody is missing what has been there before, or rather relational distress? The SDD strains a relationship, induces conflict. So I think it's important that when we think about distress, we should of course not overlook the diagnosis of hyperactive sexual desire disorder, because of course there can still be the issue that there's a low sexual desire problem. And this is an interesting question. It's a question we can discuss. And this question, which I first want to address to you, how can we now differentiate between low sexual desire as a diagnosis and then sexual desire discrepancies as a couple problem? One, a sexual desire problem is always a couple problem. Two, the criterion should be personal distress, because when there's personal distress, it indicates that it's not a couple problem, but that's a clinical individual diagnosis. Or is it undecided? So maybe you can vote on this, which question you think, which answer is the right one, and then afterwards we can discuss this. Now, SED is a clinical significant problem when both partners or one of both partners are distressed by it and request consultation. So this is our take on it. Yes. A lot of couples can easily deal with discrepancies in sexual desire for a certain degree and for a certain period of time. But a lot of times couples do experience distress and dissatisfaction in one or both partners when the discrepancy persists or grows over time. And we also see that couples feel less distressed when the level of sexual desire declines at a similar rate, or when they can accept that there are ebbs and flows in the sexual desire levels of partners. So if we want to understand the clinical implications of SED, we need to understand when the SED is experienced as a problem and what enables some couples to remain satisfied despite their discrepancies in levels of sexual desire. How does it come that some couples can easily cope with these discrepancies in sexual desire? We could look at the impact of social norms, myths, psychopathology, and so on. At this point, we do not have objective criteria to make a clinical diagnosis. So we actually don't know how large the discrepancy needs to be and how distressing the discrepancy needs to be to report a clinically significant diagnosis. What we do want to assume that the problem needs to be at least persistent and generalized, that it's not a temporary or a context-dependent problem, because as we said, sexual desire is fluid and varies over time, so that makes it important that it's at least a persistent and generalized problem. Now, when do we set the diagnosis? Is it when both partners are distressed? And then what if only one of the partners is distressed? Is it then still a clinically significant problem? We can also ask the question whether the direction of the discrepancy matters. Does it matter? Is there more distress maybe when men are the low desire partner, when women are the low desire partner, or maybe it doesn't matter? So these are interesting questions that we still need to address. So one question for you would be, under which conditions can we consider sexual desire discrepancy as a clinically significant problem? What do you think? Is it when one of both partners are distressed? Do both partners need to be distressed before we can define it as a couple problem? Or is it enough that one of both of them requests therapy and needs help? So you can answer this question and then we can discuss this afterwards. Now, there are also some conceptual issues, because if we look at the literature on SED, we were a little bit confused because there are very much different definitions on sexual desire discrepancy. Different definitions are about actual desire discrepancy, so that there's a difference between the partner's level of desire. So we compare the level of desire of one partner with the level of desire of the other partner. Or we can look at perceived desire discrepancy, that partners give an estimate of their own sexual desire and then also the sexual desire of their partner, and then we compare. But of course, there are a lot of misinterpretations involved here. Some research focuses on the difference between the actual desire, the sexual frequency, and desired sexual frequency. So how much sex you're actually having or how much sex you're desiring. Now the problem is that behavior is not a good indicator of sexual desire, because People can engage in sex for very different reasons, and it's actually quite common to start with having sex without initial desire. Of course, desire grows during the sexual act, but it's not necessary. Also, sex can mean different things for people. What is sexual behavior? What is sexual behavior for one partner is not the same as sexual behavior for the other partner. What defines sexual frequency? There are different definitions, there are different preferences regarding sexual acts. Now, because we lack this uniform definition of sexual desire discrepancy, it becomes really difficult when we want to compare the results of different studies, because different studies use different measures. So we have different findings and we cannot directly compare them. Also, we rely on different research samples. And at this point, we have very few community samples, and most often these are more convenience-based. So we don't exactly know what the prevalence is of SDD in clinical practice. So for us, it would be very interesting if you could share with us how much do you actually encounter this problem in clinical practice? Again, something that I think is interesting to discuss after this presentation. There's also a heterosexual bias. Most of the research has been conducted in heterosexual couples. And this is mainly because we assume that sexual desire problems would occur most often in a heterosexual couple because women show a lower sexual desire than men, and they show a steeper decrease in sexual desire across the relationship. So this would mean that sexual desire would be more occurring more or be larger and more distressing in heterosexual relationships. But of course, there are actually no reasons to assume this. There are no reasons to assume that SDD would not occur or would not cause distress in gay or lesbian relationships. So we really need to do more research on this, include more diverse samples so that we can compare couples with different sexual orientations or also different cultures to see how sexual desire discrepancies are manifested in these different types of sexual relationships. We do place a lot of emphasis on couple distress and that both partners are distressed by the problem. So that's why we need more measures to really exactly assess couple distress. We have a lot of individual measures like the female sexual distress scale, but we lack measures of couple distress. So we really need to develop new psychometric instruments if we really want to target couple distress. Now, when we look at the evidence, when we look at the research, most of the research focuses on the outcomes of SDD, and we focus on relationship satisfaction, sexual satisfaction, and the evidence is mixed. There are both positive and negative effects. But I think we also need to do more research on the underlying mechanisms and on the determinants of sexual desire discrepancy. We need to understand the meaning of it. We need to understand what predicts sexual desire discrepancy? How does it develop? What does it mean in the context of a relationship? Because it can mask an underlying relationship problem. We have to consider that the partner with the low sexual desire is actually the one who is taking control. This is the partner who decides when we have sex, how often we have sex. So refusing sex can be a way to regain the power and to regain the balance in the relationship. If you feel you have less power in other areas of the relationship, or when you are dissatisfied with other areas of the sexual relationship, you can actually transfer this and translate this in the sexual domain of your relationship. And of course, it's a biopsychosocial condition, so we need to focus on biological issues like menopause, disease, but also, of course, practical issues, lifestyle patterns, different preferred times of sleeping, and so on. Now, because we know that sexual desire fluctuates and varies across days, it's really difficult to make uniform conclusions on the effects of sexual desire discrepancy. And at this point, we also don't know whether the outcome of SDD is different for men and for women. We do see in research that women tend to be the low desire partner because, as we said, women tend to show lower sexual desire than men. Gender also moderates the meaning and the impact of SDD. So what we see is that for women, the level of sexual desire is not really important. It's more about how the sexual desire is embedded in the relationship context. It's more about what the effect is of a sexual desire discrepancy on their relationship. The focus is also much more on the quantity rather than the quality. It's not about how much sex they have, it's about the content, the sexual acts in itself. And often they have different objects of desire. They want different things in their partner. They do not only want to have penetration, for example. And so this is actually what induces a sexual desire discrepancy in couples. Women place less value on who takes the sexual initiative. It's not really important. For men, it's more important. They want to have kind of a balance in who takes the sexual initiative. And they also feel more satisfied when women, the female partner, are actually the one who is taking the initiative. It seems that SED is more important to men's level of relationship and sexual satisfaction. And as we already said, there is evidence showing that there's a stronger decline in sexual desire in women over the course of the relationship. So yeah, it seems especially after 1 year of relationship, we see a steep decline in the sexual desire of women. For men, it stays more constant through the years, and then eventually we see this decline. So it's actually quite common at a certain point in time, at a certain point in your relationship, that you will experience a discrepancy in the level of sexual desire. Of course, it's important that we do not put too much emphasis on these gender differences, because if you look for gender differences, you will find gender differences. I think we should also focus more on the overlap between men and women, because in a lot of ways they respond the same way on a sexual level. So there's probably much more variation within the genders than between the genders. So we should also consider researching individual differences, moderator variables, and so on. So when we think about sexual desire, of course, what does this mean for treatment? What are the clinical implications of a sexual desire discrepancy? So I want to address this question to you. What do you think we should focus on in treatment? Would the focus be decreasing the distress of the couple and working on ways to deal with the sexual discrepancy? Or should we find for the ideal frequency of sexual activity for the couple? Should we focus on the low desire partner and try to expand and increase their sexual desire? Or should we simply accept that one of both partners or both partners have a low sexual desire? So what do you think? What would be the primary focus, the main focus of treatment of sexual desire discrepancy? Which of these four options? So what is our take on it? We suggest that the main focus of treatment should not be about reducing the sexual desire discrepancy. We think we should focus on decreasing distress associated with sexual desire discrepancy and learning partners to better cope with discrepancy. So actually option one, which seems to be the less chosen option. We think this because we think we should treat the dyadic interaction, and we should focus on the function of sexual desire discrepancy and not focus on the desire itself, on the level of sexual desire. And we do have some suggestions for treatment, and these are general sex therapeutical techniques, because at this point there is no evidence-based treatment. There is no specific treatment developed for SDD, and there are almost no clinical studies. So most often the couple will present with low sexual desire. And what do? Most often we will take an individualistic approach, and we will try to increase and expand the sexual desire of the low desire partner, because this is the one causing the problem. But this is individual treatment, and this is not how we define SDD as a couple problem. So what can we suggest? First of all, I think the most important thing is to start with a good psychoeducation. Giving the couple permission to talk about sex, normalize the problem. Reframe it as a couple problem. It's not a problem of the individual. It's not a problem of the low desire partner. It's not one partner having low desire, the other partner having high desire. And then we have to make sure that the low desire partner rises to the level of the high desire partner. This is not what we want to do. We want to reframe it as a couple problem. Both are involved. We should explain that it's quite normal to experience these ebbs and flows and to experience a decline in sexual desire in the relationship. We do not always have to accept it, but at least we can normalize it, and then try to learn to cope with this decline in sexual desire and make sure that the couple is less distressed by it. One way to do this is by developing more realistic expectations. Because sometimes what we see in couples is that they have very high standards about sexuality. This is what they see on television, passionate couples and passionate sex, but it's not always passionate. Sometimes it's just good enough. And the good enough sex model explains that the desire for sex and the quality of sex may vary from day to day. It's not always super, it's not always fantastic. It's okay to once in a while have just less satisfactory sex. And we have to put effort in it to make it work. It's not going to go by itself. Of course, we should also give specific advices because it's not only about accepting and normalizing the problem. We can also try to broaden the definition of sexuality and activate the couple. Communication skills training. It's really important that couples learn to express to each other what they want and what they don't want. It's important that couples know whether the problem has to do with reduced arousability or whether maybe they just want different things in their relationship. Broaden the sexual repertoire, and because a lot of couples have a very narrow definition of sexuality, they focus only on sex as penetration. But I think it's important that when we think about sexuality and when we think about treatment, the focus should be on increasing sexual pleasure. It's not about increasing the frequency of sexual desire. It's not about increasing the frequency of sexual activity. It's also about tuning, balancing, compromising. It's about developing a joint sexual script that is satisfying to both partners. Because as I said, in the beginning of the relationship, couples have a sexual repertoire that works, it's exciting, but after 20 years, it's not exciting anymore. They want different things. You need to spice it up a little bit. So what you can do is make this very concrete and talk with the partners. Make them list very specific, what do they want? Very specific sexual acts. How frequently do they want it? They make a list, you bring the lists together as a therapist, and then you try to find a compromise. Or you can make a wish box that everyone puts some sexual acts on cards and they put it in a box, and then you alternate and you take a card of the box and you see whether you can try something out. So it's really about balancing, compromising, seeing what works for both partners. Sensitive focus, classical sex therapy, about gradually reintroducing and expanding the sexual touch. So we start with non-genital exercises, then we go to genital touching, and then we go to penetration. And often we schedule this about like 2 times a week. Each partner touches for 10 minutes. And then it's really about learning to communicate about sexuality. And it's also learning the couple that sex is a mutual responsibility. It's about giving and receiving. It's about taking and giving. So this is really important as an exercise. And it's classical. It's already there from the time of Masters and Johnson, but it's still working as a good therapeutic technique, also in case of sexual desire discrepancy. Now, the good thing is, if we give this homework assignments, like the sensitive focus, is that you make sure that couples need to schedule occasions for intimacy. They need to schedule these exercises, for example, 2 times a week. So they learn to create opportunities for having sex. And this is important. People have difficulties with planning sex because they think it needs to be spontaneous. But as we said, sexual desire is not spontaneous. If you just sit on the couch and you're sitting there and waiting for sexual desire to pop up, you will wait for a long time. You need to do something. You need to create a sexual stimulus. You need at least to start touching or doing something or thinking about something sexually to activate the sexual response. So it's really about actively searching for sexual stimulation. So sexual desire does require effort, intimacy, and planning. It's also about creating a good context, an intimate context, being nice to each other during the day so that you can prepare yourself for sexual activity, so that you can motivate yourself to open yourself for sexual activity. It's also about normalizing and depathologizing having sex without desire. It's quite common to start with having sex without initial desire, that you start having sex just because you want to please your partner. That's not an issue. Sexual desire can grow during the sexual activity. Of course, it becomes a problem when you only have sex to please your partner and you never pursue your own sexual pleasure. Then, of course, we need to intervene. But at a certain point, it's okay to once in a while just please your partner. It's, of course, also about positive rejection. You can't say no to your partner, and you need to sort of learn to decline the initiative of your partner in a positive and respectful way. It's about understanding that one partner needs to have sex, and there's also a partner who does not want to have sex, and try to meet halfway. What is also important in treatment is that we focus on the meaning of sexual desire discrepancy in a relationship. Because if we know that the sexual desire discrepancy serves important relationship functions like regaining power or dissatisfaction, we first need to resolve the relationship issues. In general, it's a good thing to work on the relationship climate and to work on relationship satisfaction, because we do see that couples are less distressed by the SDD when they are in a good and satisfying relationship. And they also are more motivated to work on their sexual contact and to make effort for it when they feel satisfied with the relationship. How can we work on the relationship? We can, of course, rely on relationship therapy. And one of the models that is interesting to use here is emotionally focused therapy. Now, according to EFT, SDD is actually defined in terms of unmet attachment needs. So when there is a low sexual desire, this has to do with a lack of emotional intimacy. So what do we do to increase sexual desire? We have to work on the emotional connection. We have to work on the level of intimacy between partners, rejoin the couple, and try to deactivate this negative cycle. Because sometimes one partner uses intimacy to get sex, and the other partner uses sex to get intimacy, and so they get trapped into this negative cycle. So we need to stop this by rejoining the couple again. Of course, there are also therapists who actually challenge this idea and who actually state the opposite. They say we should not work on emotional intimacy and connection. We should work on autonomy, on differentiation. Low sexual desire is actually the result of a lack of personal autonomy, and if there's too much emotional fusion in the couple. So it's really about novelty, unpredictability. It's about engaging in novel activities, seeking new hobbies, looking at your partner through a new gaze, trying to become less familiar to each other, miss each other so you can desire again. And so the focus of treatment would then be on differentiation instead of only focusing on joining each other and about us and we feelings. It's also about you and me again. Now, when we work and treat sexual desire discrepancy, it makes sense, of course, that we work with a couple. It's really difficult to work with individuals if we define this as a couple problem. Both are involved, so we need both to solve the problem. But of course, we can try out new modalities like group therapy or e-health. This is challenging for the future, especially nowadays. E-health is really rising in popularity, so we can also see how we can work on sexual desire discrepancy from an online treatment. So to conclude, I think there are still some issues with sexual desire discrepancy, so we need more research on the function, determinants, underlying mechanisms of SDD. I think what is most important is that we try to understand the sources of distress, because there are a lot of couples who can cope well with sexual disagreement, so we can learn from them. Why is it that some couples can cope with this discrepancy in sexual desire? And we can also have to listen to what the couple exactly wants, because again, it's not a uniform phenomenon. They are not always distressed and they do not always need treatment. Measurement tools, of course, we need to measure distress and couple distress, but it's also about measuring on a daily level, because we do know that sexual desire fluctuates over time, day by day. So it's really interesting, for example, to use daily diaries to see how this variability in sexual desire goes on a daily level. And I think the most important message that we want to give is that the treatment of sexual desire problems should mainly focus on increasing sexual pleasure instead of only increasing the frequency of sexual desire and the level of sexual desire. So our conclusion or suggestions for treatment to summarize are trying to normalize and depathologize the fact that there is variation in sexual desire within partners, but also between partners. We should educate our couple about the natural course of sexual desire, that it's normal to have these ebbs and flows in a relationship context. Emphasize the fact that sexual desire discrepancies are a dyadic couple problem. Challenge this myth of spontaneous sexual desire, because for a lot of couples, the issue is that they expect sexual desire to be spontaneous, and when it does not occur spontaneously, they present themselves with a sexual desire problem. So it's really important that we learn couples that they need to make effort, that they need to plan, that they need to create sexual stimuli to experience sexual desire. Promote open sexual communication, so that you can make sure and explain to your partner, what do I want? What do I like? What do I don't like? Trying to help the couple in developing joint sexual scripts that are mutually satisfying, but also, of course, working on personal sexual needs. Trying to explore new sexual stimuli, seeing what's out there so that they can learn about their own conditions for sexual arousal. Of course, also deal with relationship issues. When there are certain underlying relationship conflicts, we need to resolve them, and then at least promote self-differentiation. Thank you for listening to this presentation. You can read our paper in Sexual Medicine Open Access, which has been published. And I think we are open for discussion now. I'm really happy to share thoughts and ideas about this topic. Thank you for listening.
Thank you so much, Marieke. I would like to ask you, do you want to see first the pool results or go?
I think it could be interesting. Maybe also Sasha Alexander can join.
To the questions and answers. Sure. Okay, so I will show you the results of the first pool questions. You all can see it, I think.
Mm-hmm.
And you see that the majority, at least 44%, said that sexual desire problem is always a couple problem.
But it seems to be that
Marieke, Alexander?
Sure. I mean, discrepancy, as Marieke said in the beginning, we made a difference when we were talking about how the paper, in which direction the paper should go. It's not about hyperactive sexual desire. It's not about focus on individual-based focus, but it's a dyadic thing. So in my mind, in my opinion, you can have someone who looks like a perfect hyperactive sexual desire case with one partner. There's nothing with the problem when she or he finds another partner. So it's a relationship thing, that's all.
Mm-hmm. So then it would imply that every time when somebody comes in with a low sexual desire and they're in a relationship, you should at least involve the partner and see how we can resolve the problem within the couple. But do we then simply have to accept that the fact that there's one partner having low sexual desire, one partner having high sexual desire, and we simply accept it and we try to balance? Or how can we deal? Maybe people have some ideas on that?
Maybe we'll see it in the question and answer. So let's look at the second poll question. Under which condition is a clinical problem, and the majority for. What do you think about it, Alexander?
Well, again, what you usually see is that, and this will not come as any surprise for most of our viewers, each couple is kind of a universum in themselves. So in their case, I would say sometimes it's really difficult to say up front before at least the first session whether, if only one person is distressed, whether this would be enough to say, well, this is a clinically relevant discrepancy problem. So I would be sort of hesitant to say upfront, well, even if one is just, if one is distressed, that's enough. I don't know how Marieke sees this.
Mm-hmm. I think it's the same for me. I think that, I mean, you could say if one partner is distressed and the other partner is not distressed, what we often see is that the non-distressed partner will at least feel some distress because there's conflict in the relationship, there's tension in the relationship. So personal distress becomes relational distress in a way. So I think it's really difficult to be completely unaffected by sexual desire discrepancies. If at least one partner is distressed, it will spill over to the other partner. That's how I see it in clinical practice.
Right.
Yeah. And the third pool questions about the treatment, and here definitely the majority state that decreasing distress of the couple and work on coping strategy is the best way to treat this problem.
Mm-hmm.
Sure, although sometimes, you know, the way to decrease distress may be to deal with one of other options. For example, it's not necessarily that the low desire partner is the focus, or sometimes the way to take to decrease distress in both of them. Sometimes it can be a high desire partner. You know? Sometimes maybe you have a person who uses sex as the only tool to show love and to ask for acceptance, to ask for some sort of an emotional support. So sometimes you will turn to the high desire partner and again try to help the person and the partner understand what lies behind. Certainly it's always also sex behind, but sometimes it's not only sex.
Mm-hmm. What I do see,
I totally agree. I think that Marieke also said it is a look at the meaning of the discrepancy. Am I right? That's what you mean, Marieke?
yes, that's exactly what I mean. I think it's really about if we focus, what we often do in treatments is often, yeah, we tend to focus on this level of desire, like, okay, there's low desire, high desire, we need to balance it, we need to tune it. But I think it's also interesting to understand, where does the low desire come from? What does it mean in a relationship? Like I explained, sometimes it can be power issues that are involved. But I think what is also important, what I see in the questions, I just quickly scroll through it, that there are quite some issues on what about biological causes? Because when there's a biological cause involved in the low sexual desire, then yeah, can we still see it as a couple problem? Should we then still, I mean, then it's not about balancing or tuning because there's a biological cause involved. So I don't know, Alexander, how you think about that. What about, I mean, if we consider sexual desire as a motivation, of course, it's not only motivation. There are biological issues involved. There are practical issues involved, like when you don't sleep together or when you work at night. And I mean, how do we deal with that?
I think, yeah, that's basically the question that you always ask yourself, no matter what the problem or the issue is that a couple or person came with. So I would say, again, we try to talk about, you know, the sexual history of a person or a couple. If this is something, if for example you find that there is a pattern of this discrepant desire from almost the very beginning of the relationship, then it will be, you know, hard to believe that there is an underlying physical problem. Okay, but again, you know, this is what we try to stay open about, that there is a possibility that sometimes it's not all in the head. Okay, but again, I would like to know more about the history and the context before I start asking person to go around and find specialists and actually, you know, undertake some financial obligations in terms of, you know, getting treatment or getting just diagnosed or, you know, tested, etc.
I see something in the chat is not in the question that maybe you would like to respond on it. And to you, Marieke, you made no differences between desire for sex versus desire for sex with a particular partner. Some thought about that.
So that it's, yeah, that we have to, it's not, yeah, you can have desire for solitary sex as well, of course. And we can, how do you define desire? If we look at it in a sexual desire discrepancy, then it's mainly focused on a response to a partner. But of course, what about just wanting sex with somebody else, or maybe wanting sex, just masturbating, for example? And of course, we have to consider the idea of open relationships nowadays. And I am also wondering how, maybe Alexander, if you have any ideas about like this consensual non-monogamy and how sexual desire discrepancies work in that, because you could also say, hey, when there's a discrepancy in sexual desire, instead of balancing and tuning within the couple, just seek sex with outside the couple. You can sort of just suggest, hey, let's have an open relationship. I have low sexual desire, so you can go out and have sex with somebody else, for example, to sort of, that's also a way of tuning and balancing within a couple. That's also a way of dealing with the problem.
Well, I'm not sure what Uli had in mind, but two things come to my mind. One is that sometimes you see that potentially the discrepancy comes about because one partner has a pattern of arousal that is somehow it cannot be worked out with the current partner. I'll give you a very simple example. There was a guy who said, my wife does not want to kiss, French kiss. Maybe she will allow a French kiss, but not before she's very close to the orgasm. And for this guy, this was something that comes in the beginning that triggers the whole process of, arousal. Okay, so in that sense, certainly the problem with the desire problem in the couple here may be very specifically tied to how another person reacts to your sexual needs or habits or whatever. On the other side, you can have a situation in which there is an essential difference in how partners find sex important in their lives. And you have a partner who is sort of close to being asexual in a way, which other partner realized maybe 6 months after getting in the relationship. Okay, so but there is an emotional bond, and they're really keen to keep this relationship, this intimacy. Maybe they're parents; they already became parents. So maybe some of such couples would be open to the idea that, okay, maybe this sexually relationship can be opened, and that can be at least part of the solution for the discrepancy that exists now. I haven't tried it. I never suggest something like this, but I can probably see a day where, see a couple, in which case I may very gently and carefully open this subject.
Mm-hmm. Yeah, I think it's also a matter of, especially when we define sexual desire discrepancies also in terms of the meaning and the sexual preferences. Because imagine, for example, there's a couple who has SM fantasies, for example, and the other partner is not really sharing that. How do you deal with that? It can be interesting to open the discussion then and to state like, hey, because you can work on balancing and try to compromise, but at certain points when the sexual preferences are so diverse, it becomes really difficult to make a compromise. If you just don't want to engage in SM, can you then just say to the other partner, well, you have to suppress your fantasies? So yeah, I think it's a challenging topic again, because, and it proves also, if we focus on sexual preferences, that it really becomes a couple problem, because the preference of one partner, maybe there's just kind of like we say, a mismatch in behavior that it's just not, I don't know how we can think about matching desires or matching couples. Do we really have to have this sexual match to work?
I will leave it in a question because of the time, and there are a lot of questions and answers and remarks. We will not be able to deal with all of them, but I would like to say a few things. There were a few questions about how it is in homosexual couples, lesbian, gays, LGBTs, and Karina Lenz did a remark that she see a lot of LGBTQI people, and yes, absolutely, there are SDDs and SDDs among other than heteros couples. Just a remark, because there were some remarks about. Shomer did a remark that increasing sexual arousal or decreasing distress by upregulating techniques or downregulating can also helpful to decrease distress, I would think. Which is your comment on that, Alexander or Marieke?
Sure. I mean, well, what I would, I really try to assess and address the relationship bond, the level of closeness, emotional closeness and intimacy, because I think that's probably the greatest resource that the couples who are dealing, who are coping, and for quite some time with this discrepant desire, or whatever you want to call it. If they don't have this resource, I think it's going to be very hard for them to cope with it for much longer. So in that case, I think once you have partners who are really close, I think there are many options. This is one of them. And again, how do you find the right option? You don't, basically. You talk to them, and then somehow they usually hint in a way. You know, they show you what may be the closest strategy or the most probable strategy to try with them once you get to know them a little bit better. Because and let's not forget, this is not something that we try to solve in a few sessions, right? You really need to understand how they got together, what was their sex life in the beginning, what changes, what didn't change, what changed in the way that they perceive each other. Sometimes people may lose a little bit of interest sexually in other partners, but what they gain in the meantime is enormous respect and just interest in personality. Well, is this sexy? Can that be sexy? Can it be erotic? Sure, you know, under the right circumstances, and sometimes they have to learn how to create these right circumstances. Sorry.
So if I understand correctly, Alexander, you would say that if we think about this emotional connectedness in EFT versus differentiation, I hear you say that we have to work on the emotional connection, the relationship, but at the same time, I hear you say differentiation is important. It's about losing interest and being interested again in each other and some aspects of novelty.
Sure. I mean, Schnark wrote about it a long time ago. My hunch is that you will not find a lot of couples who are really that emotionally fused. You know, people are usually differentiated to a certain extent, and then you just try to work with that. You know, but again, I think, and we all probably have a huge respect for Esther Perel, but you know, and certainly, you know, security, safety is not a great friend of, it's not a Dr. Watson to Sherlock Holmes being the sex. But I think without this connection, without this emotional closeness, it's very hard for couples to cope, to deal, to try to find ways out of this distressing discrepancy.
Yeah.
In that relation, related to what you just said, Alexander, there is a remark or question to you, Marieke. Do you feel comfortable telling us if you use elements of both EFT and differentiation, or are more in favor of one, the differentiate approaches?
I think what I always approach is more like sort of a practical approach. I do not want to sort of choose a camp. I think that both approaches are worthy, because I just think it depends on the couple. It's like Alexander said, most of the couples are differentiated, and the issue can be that they are too much differentiated and that you need to reconnect them. But of course, when there's a couple who is more connected and who has sort of, lacks the autonomy, then differentiation can be more interesting. I think in general, how I think about sexual desire is there needs to be a lack. You need to lack something to desire it. If you have it all, when your partner is constantly around, when you're constantly doing things together, then it becomes less difficult to desire your partner. You need to be apart sometimes. You need to sort of, yeah, do things for yourself and have some personal autonomy so that you can desire for your partner again. So I really think it depends on how the relationship is built to see whether EFT would work better than differentiation. I think it's not a uniform solution, a one-size-fits-all model. You really have to focus on the couple relationship and the situation, I think.
Okay, very interesting, and I'm sure that we were able to stay here and talk another hour about it, but this webinar is planned for 1 hour, and we are above the 1 hour, so we will need to finalize this webinar. And I would like to thank both of you, Marieke and Alexander, for marvelous presentation and a great discussion, which I'm sure that we'll be able to do long. So maybe we need to plan more on this issue in the near future. This opportunity, I would like to remind you about the ESSM Congress that's planned for February. Follow the details in our website and newsletters. And to remind you that next week, we will have another webinar with Stephanie Both from Leiden, the Netherlands, and Elisa Mazzaroli from Italy about hormonal contraception and the influence on female sexuality. On the 16th of June, we will have with our President Carlo Bertocchi and Daniele Sormano from Germany about the satisfaction and expectation of penile implants. On the 18th of June, the use of cavernous nerve injury models in radical prostatectomy, erectile dysfunction. And on 24th of June, the use of energy-based devices for female genitourinary indication. So stay with us. Thank you again, our panelists, and thank you again, you, the attendees, for taking part of this webinar, asking questions and doing much remarks. And stay tuned with our activities of the ESSM. Good evening, everyone. Bye-bye.
Good evening. Thank you all for joining.
Bye-bye.
Thank you. Bye-bye.